Prashant Bavankole for this opportunity. And I think now that we've learned all about the Mirante system, we'll be viewing another system also which helps us with Widefield imaging. And my talk is a wider perspective, and I thought I'd cover ultra-widefield OCT and OCT angiography because that's something which is upcoming now. It is the new kid on the block, and we're finding it more and more useful to use it and pick up stuff in a non-invasive manner. I think Dr. Ajay Arora already told us that Dr. Ailo's group has defined the International Widefield Imaging Study Group recommended widefield to be 60 to 100 degrees and ultra-widefield to be about 110 to 120 degrees. And seeing is believing. So I think till you see it, you can't believe it, you can't treat it. And I love the acronym of Dr. Shane, that DREAM. So till we document it, educate our patients, and kind of reinforce it, we cannot treat the pathology and cannot convince our patients to get treated. So I think that's an amazing tip from today's talk from him. So swept source has really helped us to go wider and deeper. So basically there's no spectrometer, so there's no signal loss. And the electronic tuning is just getting better and better. You're getting faster A scans. So if you want so much depth and resolution, if it's not faster, the patient would be blinking and it would take too long. So this has really helped us with shorter acquisition times and more averaging and a better flow analysis. So how are we going deeper and wider? So now with the wide field OCT, we are doing 16 mm scans, which are up to 3 millimeters deep. So this is the advantage which we are kind of reaping a benefit of. And this slide shows the different scans over time. We always started OCTA with a 3 into 3 millimeter scan. But now we have got wider scans. We're routinely using 12 into 12. And the other scan, which is very useful for diabetic retinopathy, is a 15 into 9. So that gives a lot of information in a single scan. But wow, the wow factor comes is the montage. So this is 5 scans. Each of them is 12 into 12. So 4 are incorporated, 4 peripheral scans, and you have a center one at the fovea. And together you get, I think, a little more than 100 degrees. So this is where you get 22 millimeters by 22, a very wide field view of the retina with this montage. So let's go into interesting situations. So this is, of course, this is a nephropathy patient, PDR with multiple NVEs, and patient was not allowed to undergo a fluoresceint angiogram, and see beautifully without a dye. We can pick up the raised NVE, and we can treat this patient based on this wide field octa only. Regression of the NVE also, so we can monitor, we don't have to keep on doing invasive angiography. So I'd like you to, this is a study we published in the IGO. So this is the regression of the diabetic vessel. So you can even see the B scan. If you see this upper area, you see the raised vessels and the red dots are showing the flow. So before you can see how vascular it is, how many hundreds of red dots are within this neovascular tissue above. And post laser, you can see the red dots have gone. So there's no flow. So the B scan is beautifully correlating with the actual NVE in the periphery in this patient. And you can see the beautiful images. So here we have compared the multicolor, the regular scan octa, and this is the FFA. So you can see the leakage on the FFA, but you can't see the detail of the neovascularization. You can't see the fronts and all. But with the octa, you can beautifully see the details of the neovascularization and it regressing post-laser. Other cases, I think diabetic also, you can see beautifully, this is the FFA which shows it, but you can see the detail and beautiful kind of a front raised when you compare to the B scan. This is the octa image on one side, on the FFA on the other side. So it's a gorgeous image. It won the ASRS award. It was called the flame of the forest. So something interesting. This is the other cases where we use it. So this was a patient which underwent vitrectomy with gas bimanual membrane dissection. So pre and post-op, you can see the entire thing is flattened and the retina looks almost normal. Of course, the perfusion is not there. And a tight laser, as Dr. Ajay just told us, is the key for success, long-term success in these cases. So now I've just shown you big, beautiful pictures, but what about quantifying it? So there was a study from the US, from Washington University, which showed that the ultra-wide field protocol enhances automated classification of DR severity with octa. So this is what I think Dr. Shane also mentioned. So maybe these patients, we don't do anything actively, but you can see this purple color is the CNP areas, which by image J, they've just kind of quantified. So patient who's like spectrum J rather than F, we would call them for more frequent follow-up. So I think Dr. Shane also mentioned that the follow-up becomes much more because these are more likely to go into PDR and require laser much sooner than somebody on the spectrum of G and H. So they've actually quantified it and shown on Okta how this is important. Other diseases, retinal vein occlusions, you can see how beautifully the capillary non-perfusion and the collateral forming is picked up. CRVO, I think one of my colleagues, Dr. Charu, is doing a study, which is even sent for AO. So there's a kind of a wedge of non-perfusion. So you can see this amyleric triangle, which keeps on increasing as the CRVO goes from ischemic, from a non-ischemic in the beginning to a ischemic CRVO. So this indicates closer follow-up is required. So just going back into the real world, this is a patient where we found this modality useful. It's a right eye STBRVO NVE. PRP done all the way back in 2007. Over 13-year follow-up, there were bleeds, but vision remains fine, and only observation was recommended. So you can see the image, you can see the raised tissue here, the sclerosed vessel and the laser. Here in the Okta, you can pick up this capillary non-perfusion and this raised area which was lasered. And the most important part of Okta, I think, is that you can do section by section. So it's like a cake you have on your wedding which has got multiple layers. You can just slice one aspect of it and know what's going on there, not what's going on in the choroid, not what's going on above. Unlike a fluorescent angiography, which you can see just one section, it's like a 2D, it's looking at the top of the cake. But here you can slice the cake and see what's going on in the intervening layers. So you can see the raised NV on the VR interface slab here. Second patient I wanted to just discuss was a patient who had leukemia, TLC was 1.8. Left eye had high pressures, ischemic CRVO, a very featureless retina you can see, but the Okta clinches the massive amount of capillary non-perfusion, and both the eyes you can pick up this beautifully using the Widefield Okta. What about PCV? I think PCV, every time you go for conferences, everybody says, plays pessimist. It says that Okta, there's variable flow. Somebody says the flow is too high. Somebody says it's too low to be picked up. There are a lot of segmentation artifacts. You have these huge PEDs, lots of blood. You can't see it. So we kind of try to find out whether we can use it to help up in our PCV cases. So the ICG shows the polyps better. See these two polyps. But the BVN is shown better on the Okta. So here you can see how beautifully the BVN, the branching vascular network, is seen on the Okta compared to the ICG angiography. Here again, you can see the yellow arrowheads are showing the polyps, and the BVN is seen with the turquoise color arrow. PHCR, peripheral exudative hemorrhagic chorioretinopathy, and one of my favorite diseases, so you can pick up beautiful peripheral polyps, both using ICG and Okta in this PC, and the B scan shows you the flow in this area. So this is a Widefield B scan which is picking it up. What about Widefield choroidal imaging? So this is another PHCR study where we did wide scans, and we found the choroid configuration was different. You normally have a bowl shaped, so you have a bowl, it's at the fovea, it's the thickest, and then it tapers off. But when I studied my patients with PHCR, I found a club-shaped configuration, like a claviate. So it's thicker in the periphery, and it becomes thinner as we come. So this was published in Retina, where we proposed PHCR to be added to the spectrum of pachychoroid disease. This is just a table and a graph from this same article. So just to conclude, Widefield OCT has a definite role in diseases involving mid-periphery and the periphery, critical for patients where invasive angiography is contraindicated and where you don't want to subject patient on follow-up to an invasive test. And response to therapy is amazing. You can do it frequently. Of course, the cost, the artifacts, and the challenges in capturing the image remain the bugbears of this technique. Thank you.
Thank you, Daraius. And by the time Prashant is the next speaker, before he puts the slides on, both OCT and OCTA, do you think one day we'll give off all the angiography, the regular ICG and FFA?
I think maybe one day, but not yet, because you cannot see the leakage. That's the main problem. You can see the flow, but you can't really see leakage using this technique. So that's the contraindication. And certain other things I feel ICG is very useful is if you want to do, of course we don't have the dye now, but for pre-PDT, I don't think we can depend only on OCT for that. So these are the conditions. But sir, you're right. I think as technology evolves, we will be moving forward.
I'm also working with some company in Greece and Germany to get the Visidyne to India. So I don't know
Please share.
No, I know, but somebody told me 3 lakhs. One of my patient was ready, but I don't know why we are not able to still import. Anyhow, we hope to work on that. As a chairman ARC also, you have to do a homework to
Yeah,
get
Dr.
the
Prashant, I think
Visudyne to India.
The PDT dye, I think Dr. George was also telling me
So,
that through BRSI they're trying to.
Daraius, I have a question for you. When you showed these beautiful images, you are doing simultaneous FA and OCT in the same patient?
We did a pilot study with Dr. Shishir Narayan some years ago where we did do that. Now, since we are now confident about the Octa, we are not doing it simultaneously. But when we got the Octa new, we did a kind of same patient on both.
So when you said you found a lesion on the angiography or a particular lesion, to go to the same place on the Octa, a point-to-point, pixel-to-pixel correlation is difficult. You can approximately say it, but you may not accurately say
Yeah,
that.
because the machines are different. So you do have, I think if somebody has a Silverstone, they can do it exact because it's in the same machine.
Yeah.
But we are using separate systems. So the Heidelberg is capturing the FFA ICG and the Plex Elite is capturing the OCT. So you have to kind of do it in your mind or you have to do approximation. I'm sure you can make an algorithm for that, but otherwise you have to do it.
Prashant may have you are talking on FFA, ICG and OCT. While your talk, you can answer Ajay's point.